Before starting discussion of the main topic, we will first review a case. A 15-year-old boy got admitted to a hospital for a cardiac surgery. This is his post-operative chest X-ray, which may be a reasonable diagnosis from this X-ray. A. Dextrocardia, B. Mitral stenosis, C. Fallot's tetralogy, and D. both A and C. We will discuss the case later. Mitral valve stenosis is a valvulopathy that describes narrowing of the opening of the mitral valve between the left ventricle and the left atrium. Mitral stenosis is almost always rheumatic in origin, although in older people it can be caused by heavy calcification of the mitral valve. There is also a rare form of congenital mitral stenosis. The most important chest X-ray findings are the features of left atrial enlargement. There is convexity or straightening of the left atrial appendage just below the main pulmonary artery along the left heart border. Double density sign. The right side of the enlarged left atrium pushes into the adjacent lung and creates an additional contour superimposed over the right heart. Elevation of the left main bronchus and splaying of the carina. Walking man sign on lateral projections. There may be upper zone venous enlargement due to pulmonary venous hypertension, pulmonary edema, diffuse alveolar hemorrhage, secondary pulmonary hemosiderosis, which is often difficult to appreciate on a plain radiograph, and pulmonary ossification, which is a late sign. The diagram of the left side has normal left atrium and the right side has enlarged left atrium. In left atrial enlargement, the distance of the right border of the left atrium from the midpoint of the left mainstem bronchus is more than 7 centimeters. The double density sign, also known as the double right heart border, is seen on frontal chest radiographs in the presence of left atrial enlargement and occurs when the right side of the left atrium pushes behind the right cardiac shadow, indenting the adjacent lung and forming its own distinct silhouette. If large enough, the left atrium can actually reach beyond the border of the right atrium. This is known as atrial escape. Here you can see the double density sign. In this chest X-ray, a double contour is seen through the right side of the heart, which demonstrates the double density sign. This is another demonstration of the double density sign. Atrial escape refers to a chest X-ray sign of massive left atrial enlargement and is an exaggerated version of the double density sign. Normally, the right border of the left atrium is not visible. As it enlarges, it forms a distinct border projecting through the right heart shadow, medial to the right heart border. When the atrium enlarges further, eventually its right border projects lateral to the normal right heart border. It is this reversal of the usual double density sign which is known as atrial escape. Atrial escape is shown in these images. This patient has severe mitral stenosis. In his chest X-ray, there is massive enlargement of the cardiac silhouette. The borders of the left atrium are indicated by the arrows. Its dimension was 19 centimeters. The dimensions of an American junior football are 24 by 14 centimeters. So the junior football has a dimension of 24 by 14 centimeters. This patient's left atrial dimensions were 19.4 by 12 by 8 centimeters. This atrium has been described as football left atrium. The walking man sign is seen on a lateral chest radiograph and is a sign of left atrial enlargement. It results from posterior displacement of the left main bronchus such that it no longer overlaps the right bronchus. The left and right bronchus thus appear as inverted V, mimicking the legs of a walking man. The left one has normal left atrium and the right one has enlarged left atrium where posterior displacement of the left main bronchus is shown with yellow arrow. Here you can see posteriorly displaced left mainstem bronchus, which indicates walking man sign. This lateral radiograph shows the markedly dilated left atrium displacing the left main bronchus posteriorly, resulting to the walking man sign. These are the annotated images of the previously shown X-ray. The moguls of the heart refer to the bulges of the cardiomediastinal contour on frontal chest radiographs. First mogul is the aortic arch. Second mogul is the main pulmonary artery segment. Third mogul is the dilated left atrial appendage. Fourth mogul is the left ventricle. And fifth mogul is the prominent pericardial fat pad. This image shows the 5 moguls. This is another version. The third mogul sign can be seen on frontal chest radiograph in the presence of left atrial enlargement. It refers to an extra mogul or bump along the upper left cardiac silhouette just below the left main bronchus. This patient had a history of mitral stenosis complicated by pulmonary arterial hypertension. Here cardiomegaly with double right heart border is seen. There is splayed carina, prominent pulmonary outflow silhouettes and left atrial appendage in keeping with third mogul sign. The white arrow shows the third mogul sign. In these images, elevation of the left main bronchus is shown. The normal carinal angle should be less than 90 degrees. Splaying of the carina with the increase of the tracheal bifurcation angle to over 90 degrees is an indirect sign of left atrial enlargement. In these images, splaying of the carina is shown. Cephalisation or upper lobe pulmonary venous diversion refers to the redistribution of blood into the upper lobe vessels. It reflects elevation of left atrial pressure and can occur with pulmonary edema. It produces Stag-antler sign on a frontal chest X-ray. The normal left atrial pressure is 5 to 10 millimeters of mercury. An elevation of left atrial pressure to 10 to 15 millimeters of mercury will result in cephalisation. Now, Stag-antler sign. The prominence of upper lobe pulmonary veins resemble a stag's antlers. Acute pulmonary edema is encountered in a great variety of patients, the commonest of which have cardiac disease, usually left ventricular failure or mitral stenosis. The exact mechanism of the production of pulmonary edema is still uncertain, but a high pulmonary capillary pressure, increased permeability of the pulmonary capillaries, and a decrease in the osmotic pressure are the most important features. This is a case of acute pulmonary edema in a 28-year-old woman with previously undiagnosed combined mitral stenosis and regurgitation who had just given birth to a full-term neonate. Chest X-ray shows features of pulmonary edema such as upper lobe pulmonary venous diversion, enlarged cardiac silhouette, and bilateral airspace ossification. In diffuse alveolar hemorrhage, there is diffuse bleeding directly into the alveolar spaces. It can occur in a vast number of clinical situations, including mitral valve stenosis, where it is due to back pressure. The clinical context is crucial in image interpretation. The exact pattern may differ depending on the underlying cause. In general, the typical feature on plain film during an acute diffuse alveolar hemorrhage is a diffuse infiltrative ossification pattern. This is a case of diffuse alveolar hemorrhage in a 33-year-old man with rheumatic mitral and aortic stenosis who presented with hemoptysis. Chest X-ray demonstrates extensive bilateral diffuse pulmonary consolidation with sparing of the periphery of the lungs, creating the window frame effect that is suggestive of pulmonary hemorrhage. These are window frames. Here, diffuse pulmonary consolidation and sparing of the periphery of the lungs contribute to the window frame effect. Pulmonary hemosiderosis refers to iron deposition within the lung. It can be divided into two main types, primary and secondary. Secondary pulmonary hemosiderosis is usually due to conditions such as collagen vascular diseases, coagulation disorders, and mitral stenosis. This is a case of pulmonary hemosiderosis due to mitral stenosis. Chest X-ray shows cardiomegaly with straightening of the left heart border. In addition, there are diffusely scattered miliary nodular opacities. Chest CT axial view lung window shows randomly scattered miliary nodules. Fiber optic bronchoscopy was done subsequently and transbronchial lung biopsies were performed, which showed characteristic histological findings of numerous hemosiderin-laden macrophages within the alveolar spaces. Pulmonary ossification is described as mature bone formation with or without marrow elements in alveolar or interstitial spaces. It can be idiopathic, which is called idiopathic pulmonary ossification, or secondary to chronic lung, cardiac, or systemic disorders. It is a rare late sequelae of mitral stenosis. Chest X-ray of a patient with mitral stenosis showing cardiomegaly, prominent interstitial markings, and round to oval calcified nodules shown with arrows, which are pulmonary ossifications. This is a case of pulmonary ossification in a woman with long-standing mitral stenosis. Frontal chest radiograph shows bibasilar confluent calcific areas of increased opacity, which are most conspicuous at the right lung base. CT scans obtained with soft tissue window and lung window settings help confirm the presence of ossified clusters. Now we will see some sample X-rays. This patient has long-standing mitral valve stenosis under review for mitral valve surgery. Left atrial enlargement is depicted by straightening of the left cardiac border, which is shown with orange color, and a double right heart border, which is shown with red color. The remaining cardiac silhouette is outlined in yellow: right atrium, right ventricle, and left ventricle. There is near equalization of the prominence of the upper and lower lobe vessels, indicating increased venous pressure. This is another case of mitral stenosis. In this chest X-ray, a number of classical chest radiograph appearances are seen, although with evidence of subsequent mitral valve replacement. There is evidence of median sternotomy demonstrated by sternotomy wires. Here you can see the replaced mitral valve. Splaying of the subcarinal angle is shown here. There is prominent left atrial appendage. And you can see the double right heart border. This is the X-ray that was shown at the beginning. It is an interesting case of rheumatic mitral stenosis in which cardiomegaly due to left atrial enlargement presented as an image mimicking dextrocardia in chest radiograph. Mitral valve replacement was carried out, and this post-operative chest X-ray showed cardiomegaly with massive enlargement of the left atrium projecting to the right and upwards, resembling a dextro-rotated cardiac apex. Dextrocardia is a condition in which the apex of the heart is pointed toward the right of the chest instead of pointing toward the left. Left atrial enlargement can occur both to the left and right. A disproportionate left atrial enlargement along the right heart border with a cardiac apex-like configuration resembled dextrocardia in this case. In true dextrocardia, the heart is located in the right hemothorax with its base to apex axis directed to the right and caudate, so the direction of the apex should be downwards and to the right. In this case, the direction of the apex-like configuration was to the right and lateral. Such a positional abnormality may be seen in a radiological boot-shaped heart as seen in Fallot's tetralogy with dextrocardia. However, the presence of a double-density apical shadow indicates that these are the borders of left and right atriums. So that was a pseudo-apex and not a true apex. In short, this is a left atrial enlargement and therefore it is not Fallot's tetralogy. The structure mimicking apex is not actually an apex, so it is not dextrocardia.
Thanks for watching this video. You may like to watch other videos in this playlist. Please subscribe to our channel if you have not done yet.